Hey guys, in today's video we're going over the retrobulbar block. This is a really important type of anesthesia that comes to use in glaucoma, retina, strabismus surgery, or even sometimes in the case of a difficult or more complicated cataract. So the objectives of this type of anesthesia are threefold. One, akinesia of the globe and lids, which implies immobilizing the globe and the lids, providing anesthesia to the globe, lids, and adnexa, and adequate post-operative analgesia. To understand the anatomy, imagine the globe being placed within a cone-like configuration of muscles. The area within the muscle cone is called the intraconal space, and outside is the extraconal space. Since the anesthetic is delivered behind the globe, it's called retro for behind and bulbar for globe. An important landmark for introducing the needle is at the inferior temporal margin of the orbit, starting around lateral 2/3 of the orbital margin, as shown by the arrow here. This video goes over the retrobulbar block under ultrasound guidance. Here the globe can be seen with the optic nerve emerging from the back. This patient interestingly has a retinal detachment, which is seen as a white or a hyperechoic sheet in front of the sclera. The globe is bounded by the lateral rectus and the medial rectus on either side. The axial length of the eye can be seen on the screen, which gives us a ballpark of where the globe ends. The shadow on the lateral side is the orbital wall, and if we scan medially, we can see the medial orbital wall as well. The black shadows on either side are again the medial and the lateral rectus muscles. And here's the nerve again. So to start, the skin is cleaned with the sterile technique. A 27 gauge needle is introduced at the infratemporal margin of the orbit. The needle is then directed superiorly and medially towards the orbital apex to enter the muscle cone. Once the needle has reached the retroorbital space, the syringe is aspirated to ensure that no blood vessel has been entered and the anesthetic is injected. The tip of the needle can be seen here along the lateral border. This is where 4 cc of anesthetic is going to be infiltrated. Now we're going to start walking medially to the other side of the eye, making sure that we stay away from the globe and remain superficial. Once we're just beside the medial rectus, another 3 to 4 cc of anesthetic will be infiltrated. Watch the globe for gentle proptosis and ptosis all this time, which would indicate that the block is taking effect. Immediately following the injection, firm pressure is applied with a 4x4 gauze to help with the anesthetic to diffuse. So let's go over the intraconal components that are anesthetized by this block. The optic nerve, cranial nerve 3 and 6, the nasociliary, which is a branch of the 5th nerve, and ciliary ganglion all affected. Blocking the motor components prevents the movement of the globe, and blocking the sensory nerves causes anesthesia. Complications from retrobulbar block are rare, occurring in about 1 to 3% of patients. Some of the common complications include a bleed in the back of the eye, which is a retrobulbar hemorrhage, perforation of the globe, a subarachnoid or intradural injection of the anesthetic, diplopia because of muscle toxicity, or cardiorespiratory distress. So that concludes our discussion of retroorbital anesthesia. I hope you guys found this video useful and educative. So guys, keep learning, keep asking questions, and I hope to see you soon again. Take care. Bye.